I'm going to go over the COVID-19 vaccine-specific slides from February 28th. If you'd like to check them out yourself, you can go to this link right here, where prior to this meeting, the qualifying criteria were that everyone aged 5 years and older should get 1 dose of an updated COVID-19 vaccine, that children aged 6 months to 4 years need multiple doses of the COVID vaccine to be up to date, including at least 1 dose of the updated COVID-19 vaccine, which is the 2023-2024 configuration targeted to XBB 1.5, and that people who are moderately or severely immunocompromised may get additional doses of updated COVID-19 vaccines, so long as their last vaccine was 2 months ago. Shifting to their presented epidemiology of COVID-19 associated hospitalizations among adults, so this is people 18 years and older. The highest prevalence groups of COVID hospitalizations is 50 years and older, where between October 2023 and January 2024, 46% of COVID hospitalizations were in those 75 and older, and almost 2/3 of the hospitalizations were for those 65 and over, with those under 65 making up the final third. The caveat is that this data and the rest of the data based off of the COVID net only consists of 98 counties in 13 states. So the data is only based off of approximately 10% of the US population, where the representative percentage of state coverage based off of the COVID net is given by the different colors, where for instance the majority of the states that are covered in COVID net are this light yellow, which means that they're only making up 9 to 32% of the state's population. So a lot of this is working from a very limited data set. Now, interestingly, among adults that were over 75 years of age between October 22nd and November 2023, 25% of the COVID-associated hospitalizations were residents of a long-term care facility, which also means that 3/4 weren't part of a long-term care facility, but also demonstrates that the long-term care facilities need to really step up their game in terms of protecting their elderly residents. Next, looking at the weighted percentage of hospitalizations that resulted in deaths, the highest death proportion by age group is for those 65 to 74 years old, but is essentially pretty constantly high for anyone over the age of 50. And what's really interesting is that 67% of these deaths occurred in hospital and 33% occurred less than 30 days post-discharge, indicating that if you were hospitalized and then discharged, there should be a follow-up period for the first month afterwards to make sure you're doing okay so that you don't spontaneously die. For COVID hospitalizations with those with immunocompromising conditions, it was pretty consistently high across all age groups, demonstrating that a COVID infection in immunocompromised individuals is a high risk factor for being hospitalized for COVID. And while this is a significant risk factor, the bulk of COVID hospitalizations were not immunocompromised. However, while a larger majority of patients were not immunocompromised that were hospitalized, a larger proportion of immunocompromised individuals then died in hospital than those that were not immunocompromised, demonstrating that having immunocompromised COVID infection and hospitalization results in a higher risk of death. Now, all across the board in our population, we are largely under-vaccinated, where the current XBB 1.5 vaccine is the teal, the bivalent is the yellow, and essentially not having been vaccinated within at least the past 2 years is gray, which demonstrates that the overwhelming majority of people that are being hospitalized with COVID have not received a vaccine within the past 2 years. And this is most strikingly evident in those 18 to 49, where the 18 to 49 age group are the ones that have the lowest vaccine coverage, so makes sense. Where we have the highest uptake in vaccine coverage in adults for the most recent vaccine being 65 and over, and children have even lower rates of that vaccination. And what's very interesting is that 2/3 of people are willing to get vaccinated, where only about 33 to 40% are saying that they probably won't or definitely won't get vaccinated, where the current estimates is that about 21% of the population have received an updated COVID-19 vaccine, but this number should be taken with a grain of salt because it's based off of a survey where people just get randomly called and then say if they got vaccinated or not. COVID vaccination coverage was lowest in rural areas, where there's a massive discrepancy in that those without insurance are very unlikely to get vaccinated, most likely due to the financial barriers, the large inaccessibility of the Bridge Access Program, and issues such as covering this on Medicare Part D and having that switched over to the PACCESS program without having mass information shared about this. And there's also wealth disparities where those making $75K and over were the most likely to get vaccinated. Or for adults that were concerned about the effectiveness of the vaccines, this is what they reported their concerns being. The concern of this majority is that it wouldn't prevent them from getting sick, and that it may not be effective against a new variants, and that it will not prevent infecting others, followed by it will not prevent serious illness. And I think this comes down to a lot of lack of clarity behind the vaccine messaging. It's been very inconsistent. It's been very poor by the CDC. They've done a terrible job at this. So the major points that I would like you to take away from this is that vaccination provides a broadened immune response and a more durable immune responsiveness. Infection is not generating as strong signals in terms of immune protectiveness, and it's only giving a very focused immune response to specifically what you were infected with, which means a vaccine is much more likely to give you protection against the new emerging variants than getting infected with a single variant. It will not prevent you from getting sick, but it will reduce the severity of illness, especially if it's closer to when you were vaccinated, which is why we need more frequent vaccine rollouts and vaccine updates, and a higher frequency of vaccine availability for everyone, not just the immunocompromised and not just the elderly. And no, vaccination will not prevent others from getting infected. What will help with that is masking and other non-pharmaceutical interventions, the NPIs. And the thing is, if we get enough people vaccinated consistently, then we will prevent serious illness in the most vulnerable people, because that's how a true herd immunity works. And unfortunately, we have declining perspectives surrounding vaccination, where less people think the vaccine is very or completely safe, less people think it's important to get vaccinated, and less people are concerned about getting COVID, which all comes down to this inconsistent messaging by health professionals, by the government, by the CDC, by the World Health Organization. It's the messaging, the communications that's the problem. It's not this vaccine hesitancy. It's like gaslighting because they're blaming their own failures on the people instead of accepting that it's their fault and their lack of messaging. Because, for example, when we look at practitioners that are recommending COVID vaccines to their patients, this is healthcare providers, healthcare practitioners. Immediately after the vaccine became available, only 36% were recommending them to patients, and that number has dropped to about 20%, which is a huge communications problem if you're not having the people on the front line even recommending them to their patients. And these were the reported reasons by healthcare providers for not recommending the COVID-19 vaccines. The majority implied a medical reason for not getting vaccinated, which might be okay, might not. A self-perception that the patient would refuse the booster before they even offered it to them. Their belief that patients are tired of hearing about COVID-19 vaccines. The belief of high levels of vaccine resistance in community. The belief that the patient won't have severe COVID-19 symptoms, or that the bivalent vaccine doesn't provide enough additional protection, that they didn't have enough time during the visit to discuss vaccines. The belief that vaccines are unnecessary if they had COVID-19 infection prior. There wasn't enough time during the visit to give the vaccine, and the belief that the bivalent vaccine didn't reduce COVID-19 severity in this age group. So healthcare providers are clearly uneducated on the matter, or they are self-limiting in the majority of the group, or they literally just have poor time management, which is pointing to a very huge flaw in our healthcare system, where the potential reasons for primary care providers to not stock COVID-19 vaccines that they also reported were perceived low interest for COVID-19 vaccinations in the patient population, the cost of the COVID-19 vaccine and other associated vaccination costs, the healthcare system decided to not stock the COVID-19 vaccines, and the availability of the COVID-19 vaccines elsewhere in the communities like pharmacies, pointing to another very huge problem. PCPs essentially dropped the ball and just assumed pharmacies were going to take over and pick up the slack. Now I'm going to rapid fire between these. These are all going to be vaccine effectiveness associated, which is the likelihood of preventing severe disease cases, all associated with the 2023-2024 COVID vaccine. The vaccine was 36 to 74% effective in preventing symptomatic infection for non-JN1 variants, and 22 to 62% effective in preventing symptomatic infection in JN1 variants. The effectiveness waned over time for dose for all ages, with the lowest vaccine effectiveness in those 50 years and older. A similar trend was seen in hospitalizations, with the weakest effect being in those 65 years and older, where the vaccine effectiveness is dropping from 61% to 22% in those 18 years and older, showing that the efficacy of the vaccines is really only lasting about 4 months, or adopting a 2-dose strategy would increase this efficacy, where they do an estimated cost per quality life year assessment, which is a dumb way to do it, where they're essentially arguing that it's more cost effective to target the 65 and over than everybody, despite everyone needing it.